Welcome everybody. It's lovely to see lots of people joining us at lunchtime. This is the first time we've done a lunchtime webinar, so we'd love some feedback if this is a good time for you or not, how it works and fits into the day. But it's a new thing for us. But as with all our webinars, it will be recorded and posted up onto our YouTube channel, so it can be accessed at other times or shared with your colleagues. Best way to access that is through our Twitter. And I will post the link to that for anybody who's not on there already. But without much further ado, again, my name's Libby. I work on the MSc programme. I'm part of the faculty here. I'm one of the readers in clinical education at the Blizzard Institute at Queen Mary's. And I'm going to hand over to Prof. Harris, who set up the whole of the MSc programme and is our leader. And hopefully you'll find this a really interesting half an hour. Some of you are on lunch, and I get that. So if you need to disappear off or if you're on calls, then that's absolutely fine. And we will carry on and have a Q&A after the half an hour for those who are able to stay on for a little bit longer, but we're not, you can go when you want to, obviously. Over to you, Tim.
Libby, thank you so much. So, ladies and gentlemen, welcome. My name is Tim Harris, and I work as Professor of Emergency Medicine at QMUL. I'm currently seconded down in Australia doing some pre-hospital care. And this is a talk about front of neck access, and it is an experience rather than an evidence-based talk. And it's been put together by Libby and myself to share what we've learned over the years. So we are going to talk a little bit about the evidence, but that's just a couple of slides. We're going to review the technique, and then we're going to look at DAS versus vortex. And I'm sure both of these approaches to difficult airways are well known to many of you. And then we're going to look at a case study, which is the majority of the talk. And I've chosen this case because it went extremely well. And it was the last front of neck access I was involved in. And I wanted to reflect on why it went well and what we can learn from that. So look at the evidence. I think the largest observational study is NAP4. This is the Royal College of Anaesthetists in the UK, year-long observational study of major complications of airway management. Now, the caveat here is, unfortunately, they didn't look at pre-hospital care. So this is just emergency ICU and operating theatre. And we can see there's about 184 events, and just under half were emergency front of neck access, FONA. And only 10 of these were performed in the emergency department. So it's still a procedure that predominates in the OR. Now, I think there's two really useful bits of knowledge that came out of this. The first is that the time from can't intubate, can't oxygenate, can't ventilate to cardiac arrest is 45 minutes to an hour on average. And reflect, when we're teaching this in simulation, often the movement from can't intubate to can't ventilate is a few minutes, with the patient often succumbing and dying in a few more minutes. So what we sim for is often not the reality. And certainly I think that's a key message. Still 1 in 4 anaesthetic deaths. And of course, there are clear risk factors for the need of front of neck access. Perhaps most important to us is head and neck trauma, burns and anaphylaxis, although ENT malignancy and infection is obviously up there, perhaps less our practice. The second key piece of information was the high failure rate of surgical crike and the high success rate of scalpel technique. And almost all professional bodies now have moved over to the scalpel technique. The second piece of information I want to share with you is the exponential increase in complications during RSI as you get to 3 or more attempts. So the incidence of significant hypoxia jumps from 12 to 70% on third and subsequent intubations. The risk of aspiration goes up 13 times and the risk of arrest 11 times. And of course, this is why we absolutely emphasize that your first attempt should be your best attempt and fully optimized. So technique, here is a larynx. So we can clearly see the thyroid cartilage, the large floating Adam's apple that you can see more easily in men than women. Immediately below that, you've got the cricothyroid ligament and membrane, and that's just above the cricoid cartilage, which is about the level of C6. Now, key is that if you just use your eyes to identify it, you're going to be wrong somewhere between a half and a 1/3 of the time. If you bring your fingers and give yourself a laryngeal handshake, fingers and thumb either side, you improve to 70%. But it's still less easy to identify anatomy than you may imagine. And not surprisingly, ultrasound can improve this. If you put your transducer just under the chin and come down to the Adam's apple, you will see the cricoid cartilage. And this has got an absolutely characteristic shape, as you can see top right. As you move inferiorly, you will come to an airline. That's this reverberation artifact here, and that tells you you're over the cricoid over the membrane, and you lose that artifact, and the echogenic stripe of the cricoid cartilage then becomes more prominent. And then as you go further towards your feet, you get another airline. So this is TACA, and this is how we use ultrasound in transverse plane to find the right place. So technique. So there are 3 techniques. The cannula technique, we're not going to talk about, it fails. The surgical technique, we're not going to talk about, we're not surgeons. Almost all pre-hospital and in ED and anaesthetic experts teach the scalpel technique. This is simple, it's got a very high success rate, and it's something that is very rapid. It involves taking a scalpel, and personally I prefer a curved rather than a straight scalpel, and inserting it into the lower third of the cricothyroid membrane and pushing it straight through the skin and the membrane with a stab. You then enlarge the incision, and then you turn the scalpel through 90 degrees, usually at the where the blade and the plastic of the handle meet, because it's toughest, and that enlarges the stoma. You insert the bougie and then the tube, and the bougie and the tube should be well lubricated. And personally, I use a 6.5, not a 6 tube, because it's just much easier to get off the bougies that we use here. So the Difficult Airway Society has given us this very prescriptive but very clear approach to difficult intubation. We start with plan A. We use face masks, pre-oxygenation or NIV. We then move to tracheal intubation. If that's failed after optimizing, we move to a supraglottic airway device. If that fails, we go back to face mask. And if that fails, we go to emergency front of neck access. And this is clear. But it may be not as useful as a decision-making tool, but rather as a what-to-do tool. And Vortex was developed in Sydney by some Australian anaesthetists as a clinical decision-making rule. And it says you've got your 3 lifelines to oxygen: face mask, tracheal tube, and supraglottic airway. And you can have up to 3 goes with each of these to adequately oxygenate your patient, but you only have a second or third attempt if you can change and improve something. And these are called their optimization strategies. And these will be well known to many of you. For instance, you can manipulate the larynx with a backwards, upwards, rightward maneuver, or bimanual manipulation to improve your laryngeal view. You can put in nasal or oral airways. You can change the size of supraglottic airway, the size of face mask to get a better seal. You can use suction to clear secretions, or you can use increased amounts of paralysis to drop jaw tone. And indeed, inadequate paralysis is a common reason for a failed airway. So the Vortex describes adequate oxygenation as the green zone. And adequate does not mean a number, because adequate oxygenation in a 90-year-old with COPD and heart failure with home saturations of 84% is very different to a 20-year-old fit and well athlete. So the emphasis here is not on what's my saturation, but what do I think it's going to be in 15 minutes, and what's that going to do to the patient? And this emphasizes the steady, progressive preparation before action of a surgical airway. The process of optimizing what you're doing, optimizing your tools, optimizing your physiology, mobilizing equipment and personnel, and checking the kit. And then when this is done, move to the strategy and then declaring an airway emergency. So this is about priming for success. Call for help, set up your team, allocate procedures, allocate tasks, ensure your kit is ready, open, and checked. And then ensure the team is ready. And then when you're ready, declare you need to do a rescue FONA, and then initiate it. So now let's move to a case study. Now, I've been involved in sort of 12 to 15 episodes of front of neck access over the years, and the minority of these have me been doing them. This is in the role as a mentor, a team member, where I've been rung because there's an airway gone wrong in a place I've supervised, debriefing the next day with a team that's done front of net access, and so on. So it's all direct experience, but not necessarily these hands that were involved. So this is a 70-year-old man. He's presented to a large but very isolated hospital, and he's come in with a sore throat, tightness in his throat, subjective breathlessness. He's walked up to reception. There's no fever. He looks well. He walks through into majors. He sees the resident. There's no real other history of note. His voice is normal. There's no stridor. There's no hot potato voice. His phonation is normal. He's got a history of hypertension, triple vessel disease. He's had CAGs, but he's got residual ischemia, and he's refused any further treatment. He's very poorly compliant with his medications. He's assessed by a junior doctor who notes normal physiology, and on direct inspection, she can see the tonsillar bed. She can see the pharynx. There's a little bit of edema. There's no pus. There's very mild swelling, and there's really not much. In fact, she's much more impressed by the woody hardness and tenderness down the left side of the neck. She does a blood gas and some other tests. The blood gas is normal, and she goes for lunch. About 30, 60 minutes later, the nurse notices the patient's sweating and his respiratory rate has rapidly increased. He's not moving accessory muscles, but he's a bit agitated. He looks sick. She calls the consultant. The consultant doesn't know much about this chap, but says he looks really unwell. I'm going to take him to resus. As they get into resus, he develops soft stridor. He's got oxygen, and the consultant prescribes and delivers an adrenaline nebulizer with 5 milligrams through a conventional nebulizing device. About a minute later, this guy stands up. He starts shouting. He rips off his oxygen mask. He threatens the staff. I was just intubating a patient in the next cubicle, and we just finished, and I walk round the door and I can see the SATS monitor shows 100%. He's got a sinus tachy of about 160. Well, I think it's a sinus tachy. It's hard to see the P waves. I watch, he goes stiff. He falls back into the bed, and he has a couple of tonic-clonic movements. We then approach him, and he is in cardiac arrest. He's become deeply cyanosed. So the senior trainee takes the airway, I take team leadership. We have access checked and it works. We notice that he's in a PEA arrest around 130 to 140. We think it's sinus rhythm. The airway doctor says he's quite hard to bag. She inserts a supraglottic airway. He's baggable. The SATs are recordable with CPR, and after just 2 cycles, we get ROSC. His SATs are in the low 90s with ROSC. We perform a rapid echo, which showed a hypertrophied small left ventricle. It's hyperdynamic. Doesn't look particularly well filled, but there's no obvious regional wall motion abnormalities. Then we move to an attempt at intubation by the senior registrar, and this is what we see. There is gross edema, bubbles, very hard to make out any structures at all. There are numerous folds like this one, folds of mucosa that look like the epiglottis, but look like the laryngeal inlet, but aren't. So on seeing this, because I could see the screen, I was concerned we get an immediate gas. That shows there is a mixed respiratory acidosis. We then move on to get a supraglottic airway device optimized. Its position is optimized. And I call on a consultant anesthetic and a consultant surgeon and ask for the front of neck access kit to be checked. We assign a dedicated doctor to get that out and check it, and a second doctor, a very experienced emergency physician with an interest in airways, prepares to do a second intubation. This is just a repeat of the first. And it's clear that we should have no more attempts by the people in the room. We set up the kit for front of neck access. We talk through. We dedicate a nurse to get anaesthetic drugs. We dedicate a doctor to put in 2 more IVs. We dedicate a doctor to look at the monitor and keep his hands on the femoral pulse. So we've got checking with fingers and checking with eyes. And we talk through our front of neck access. Once we finish that, the anaesthetic consultant arrives and she immediately asked us about the supraglottic airway before we gave a handover. And then her and her team turned their backs on us and continued started their checking. We reintegrated them into the team, but this CRM proved a major issue as we debriefed the job later. I don't think anybody was trying to be rude or disrespectful. This just highlights the stress of these unusual and difficult situations. Unfortunately, the bronchoscope that was bought was broken, and the consultant popped up to theatre to get another one. We re-evaluated and we said, look, we've got SATs of 92 to 94%. We've got a really experienced anaesthetist coming back. We're absolutely ready. So we didn't proceed straight to FONA, but we did a talk through where me and my consultant colleague prepared to do a 2-person front of neck access. And we used the kit, we cleaned the neck, we injected some adrenaline with local anaesthetic, and we did it using the kit without actually performing the procedure. This meant the whole team had the same mental model. We then proceeded to step back. The consultant anaesthetist returned. She tried to do a bronchoscopic intubation and the SATs dropped rapidly down to 68%. We abandoned this and we then proceeded to optimize for front of neck access. Now we positioned 2 pillows at the head for the tragus to sternum. We were able to remove those. We left 1 pillow under the neck, exposing the neck into an ideal position. Using 2 people as our team, both consultants, we then proceeded to locate the cartilage, and I tried to put the scalpel in, and I couldn't. It just would not penetrate the membrane. So I did what Daz said and did a vertical incision, dissected open the neck with some gauze, and I could see that actually the cricoid cartilage was overlined by the thyroid cartilage and the membrane was vertical, and that's why I hadn't gone in. As soon as I could see this, I know my anatomy, so I just went in at 45 degrees with the scalpel, and my colleague placed the bougie and I placed the tube, and it was all very, very easy. We confirmed diaphragmatic movement with ultrasound, inserted a nasogastric, and then we decided to have another look in the airway to see if we could work out what on earth was going wrong. And we could see these folds of mucosa, and they looked just like the inlets to the larynx. When we fiddled around a bit and we noticed there was some edema, we couldn't see any pus or infection, and then we were able to expose the laryngeal inlet, which drops down there. And you can see it's pointing off about 45 degrees. It's very swollen and very small. So we were confident that we wouldn't have been able to intubate, and we then tidied up the front of neck access. We double tied the tube. We repeated a blood gas, which showed a combined respiratory and metabolic acidosis, but significantly improving on the one we'd done in the arrest. We inserted an arterial line, central line. We put a NORAD infusion because his blood pressure was quite saggy, presumably because he'd had an hypoxic insult to an already ischemic heart. We gave some Hartmann's, and we did an echo, which didn't show anything that the small focused echo had shown earlier, and off we went to CT. Coming back from CT, we'd now 90 minutes, and we had completely normal gases, which was very reassuring. And here is the CT, which I'll just play for you to watch. We had a consultant ENT surgeon in another hospital and a consultant radiologist in this hospital, and both were able to offer their reports that they thought this was just edema. There was no malignancy they could see, there was no infection, just gross widespread edema. And here are the coronal views. And while you're watching the coronal views, we repeated the OBS. There was still no temperature. The white cells came back as 7. The neutrophils and lymphocytes were both normal. The CRP was 2. And all our other blood tests were completely normal. So we were a little surprised at this. And we decided to take the patient to theatre. The surgeons performed a formal tracheostomy. The patient went to intensive care where they were moving at 24 hours, and they made a full recovery. And we believe the diagnosis is most likely to be local trauma, inducing some angioedema precipitated by this man being on an ACE inhibitor. He had taken his ACE inhibitors this day, which was quite unusual for him. We wondered why he got so agitated with the nebulized adrenaline. I've seen this twice before, where somebody with active ischemic heart disease doesn't tolerate an adrenaline nebulizer. And I presume that this was an ischemic insult. He'd given himself a stress test. So let's move on to what we learned from this and what we'd like to share. So looking at what went well and what we could do better, assigning roles was really important. Giving a team of one or two clear instructions and clear tasks made the process easier. Talking it through once and then acting it through meant everyone shared the same mental model. The use of adrenaline and lignocaine meant the bleeding was minimal, and checking the kit so carefully meant we had confidence in what we had there. We made the call very early. We prepared after just one intubation, but I think all of you would. If you'd seen this guy's airway, well, you have seen this guy's airway, none of you would have been optimistic of success, even with an experienced anaesthetic backup. We did limit attempts. One of the things I've learned over the years is recurrent attempts lead to disaster. And because you fall off the cliff slowly with the can't intubate, can't ventilate, doctors are often encouraged to just try one more. Oh, there's a more experienced person coming. We set FONA criteria, we stuck to them. Things I've learned over the years, always keep something in the hole, whether it's a chest drain or front of neck access. I think once you've formed a stoma, you need to keep something in it. Keep the scalpel until the bougie goes in, till the tracheal tube goes in. Mistakes I've seen where this has failed over the years, the commonest thing is because they lost their access to the stoma. It's very important to vary your technique. Daz absolutely says this, that if you don't get it early, vertical incision, dissection, have a look directly at your anatomy. Be really careful with the scalpel wall. Two of the cases I've debriefed, the scalpel, and this was both a triangular rather than a curved scalpel, cut through the wall when it was being rotated, cut through the posterior tracheal wall, and then when the bougie went in, it went through the cut and created a false lumen. That's a really difficult thing to get out of, because of course the false lumen curves down and the bougie drives the endothelium deep into the trachea. I do think it's much easier with a size 6.5 rather than a 6 tube. I do lubricate the tubes. It's when you're stressed, it's really hard to get things off that bougie. Also, stop heroic attempts. This is not the time for the one person that's done a fibre optic course to put their new skills to the test. I use a curved blade for the reasons I've said. Talk through, communication. This completely reduces anxiety in the room. And your role as team leader, the number one thing a team leader does is it stops the most dangerous infectious disease in medicine, which is anxiety. It's a simple procedure. The challenge is when to do it and making the decision. I think it's absolutely important to be a complete team player. Bring the team with you. But once you've decided to do it, be a dictator. That means silence. Once you've decided you're going to do front of neck, it doesn't matter what else happens. If the patient goes into VT, you're still going to finish. So ask the room to be silent. And the last thing you want is someone going, SATs are 86, 85, 84, because that really doesn't help you relax into the procedure. Be aware, who are you calling? What are they bringing? It's not always good to call for help if you've already got help there with you. This is a complex CRM, and every additional person brings additional complexities. Have confidence in your ability. And remember, slow is smooth and smooth is fast. Again, one step at a time, talk it through. For me, I control my fears of these things by talking. Okay, Libby, I've got the scalp. I'm going to hand this to you. Can you put on the tube? And by talking, I go at talking pace, not thinking pace, and it's much better. So overall, the Procedure is rare. Many of us will go our careers without doing front of neck access. Remember that deterioration is usually slow. It takes 45 minutes to 1 hour from going from, wow, difficult intubation, can't intubate, to death. You have time to prepare, usually. But the trouble is, because it's a slow slope that you're falling off, it makes it really hard to, guys, this is as far as we're going down the scope now. And as vortex teachers, make that decision before you're hypoxic. You want to make the decision to do a surgical airway while you're safe to do it, and you've got optimum physiology, so you're not feeling the pressure of hypoxia push you out of screen. Do record it. I'm really pleased to record these things. I wish we'd had a video in the room, because the best teaching is watching other people make mistakes or do something well. I wish I'd involved a trainee. I involved a senior consultant. I was a locum in this hospital. I've been there a week. That didn't make me feel any better. But there were 3 trainees there. And what I should have done is had the trainee doing it. This idea that you should always have the most experienced people absolutely denies giving the trainees experience, and they're the one who's going to do it for the next 30 years. I do wonder if having set cards for front of neck access is useful as a thing for all resources. The Vortex website has some and teaches this, and it gives you talk through checklists. When I've simmed this and suggested, I've been told, no time for that, you've really got to memorize it. My experience from the, I don't know, 12 or 15 I've been involved in is there is time. I've not been involved in one case where they went in 2 minutes from can't intubate to hypoxia to arrest. I'm sure that happens, but I think that's less common in our practice. And I wish we could switch off alarms. Alarms firing off during a procedure is rarely helpful. This room had about 15 people in. The best alarm, my colleague's eyes. The last thing I needed was the alarms going off. And I've spoken to manufacturers about this, and I'm told, no, you can't just disable alarms, it's illegal. I think that's a shame, because 1, the only alarm you want is the one that makes you act. And 2, once you've acted and done all you've done, an alarm is not going to change your behavior. So, ladies and gentlemen, I would love to hear from you. What's your experience of front of neck access? And what wisdom have you got to share with us? So I'm going to hand back to Libby. I'm going to stop sharing my screen, and I'm going to look forward to learning from you guys.
Super. Thank you so much, Tim, and beautifully timed. That was a real whiz through, because we were just trying to make sure we got content in there, but now we have some time for anybody who's got questions for Tim. So there's no questions yet in the chat, but if anybody would like to, you can type in the chat, or if you want to turn your mic off and you can ask a question directly, then that'll be absolutely fine too.
I'm particularly interested to see if you've got different experience to what Libby and I have got, or if you've seen something in a slightly different way, particularly with the times.
Yes, Martin, go for it.
Hi, as no one else has put their hand up, I'll go first. Hi, Tim. Nice to see you.
Martin, lovely to see you after these years.
Yeah, I've been involved in a couple of surgical airways throughout my career, either as part of a team or observing other teams, which I've had a great opportunity to do. And I just think, if you're asking about experience, I think reiterating the points about the preparation, the early preparation, and linking that to anxiety. I've spent my career in pre-hospital care, and the ones that I've seen go wrong is accounting for that cognitive load. Or you're usually doing this when things haven't gone as you would expected. So you're cognitively maxed out, you're stressed, and I find you tend not to follow your processes or your procedures. So essentially, a team's panicked and haven't followed what they're trained to do. And it's just worth bearing that in mind when you're training. Hard to train for, but the reality of doing this is you can train, and then it just hits you. You're just not expecting it. And then you've got to do one. And it's just trying to maintain that calmness that you talked about, and all the preparation that you talked about. It's so important. I mean, it sounds obvious, but just to account for when you're doing that in a hospital or in a pre-hospital environment when you weren't expecting it to happen, because it just throws your mind out. And the other thing that came to my mind was blood. There was a lot more blood than I thought, certainly in my very limited experience of seeing this. Maybe that's because we, the procedure wasn't right. There's just a lot more blood when the incision was made. And just to re-emphasize, is that keeping something in the hole, definitely. So my experience, yeah, these are done when you're cognitively maxed out. Tend not to always follow your training. So that early prep, that's my lived experience of it. But it's been really useful listening to you and watching your slides, Tim.
Thank you. I mean, obviously, I agree with everything you've said there. And I think the way to stay with your training is to go slowly and talk. And I know when I train, and for me, I'm a sort of human that solves anxiety by preparation. And I can remember all through my training, I would talk myself through surgical airways as I went to work, and talk myself through intubation. So it just got programmed here. And then for thoracotomies and anything else. And I find by talking, it slows me down, because I think we all need to know ourselves and what creates anxiety and how to solve that anxiety, because what you described about going off script, that's anxiety. You go off script because you're worried about the people in the room or something. And if you talk and you verbalize, you thought broadcast, if you like, I think that really helps you stay on your own script.
There's a comment from Holly who says, fantastic session. She works for the Welsh Ambulance Service and only had to do it once. They carry the quick tracks, which are a lot better than cannulas, but it's stressful to do it on a patient first time. And I think there is that real challenge when you've done things in simulations. I did a lot of simulation. I did a simulation post for a long time. I went back to the training. First time I put in a central line, I was like, there's blood coming out everywhere. And my colleague who was supervising me just laughed, because you forget that in a real patient, obviously there's a bleeding field and that's what's going to happen. So there is that difference, and things won't be identical between a simulated scenario and doing it for real life. So these tips and talking it through and thinking it through are really, really key. That's really, really important. There's no questions at the minute. Can you put your hands up if you have had to do a surgical airway front of neck access in a real patient? There should be a raise hand button at the bottom of your Zoom call. I mean, it is super rare.
Holly, yeah, two of you. Holly, just one comment. I think those pre-prepared kits usually involve a trachea that's rigid, and those are really hard. I would always suggest using a bougie and a tracheal tube, because the tracheal tube's pliant makes it easy to get in. I've never used a preparatory trachea kit on a living person. I've tried them on the dead when I've been just simulating or just trying out this procedure on cadavers, and they are so hard to get in, because you're trying to get them around the corner. And while I've not been involved, just as I was speaking to people in preparation for this talk, it seems that they create the false tracks, and they're so rigid that they scrape up that posterior wall. So personally, if I had my way, they would not be on anybody's difficult intubation kit. That's my view, by the way. That's just, it's not for me to tell you what you should and shouldn't have there.
I mean, there's a couple more things just coming through, which is great, but also please note in the chat that there's a link for just giving us a quick survey response, just to find out about your experience of the Lunch and Learn webinar. We'd love to hear from you, just to see about timing, where in the world you're joining us from, if these work for you, so that would be great. Thomas Lowe's also commented that verbalizing what I'm doing and I'm finding during high stress situations has been very important development in my practice. It's been said, I find it much easier to process information and stay calm. And there's a thing called sharing the mental model, which I think some of you may have heard of, we've talked about, and it's about that speech bubble that you have inside your head, but actually can you put it up and into the middle of the room and go, this is what I'm thinking, what are you thinking? Because people think you must have realized that the patient was anaphylactic shock. You must have realized that actually the SATs had gone down to 60% or 20% or whatever it might be. And unless you verbalize, people don't go, oh God, actually, they haven't realized that yet. Let me help fill in that mental model. Or they can see how they can support you because they can see where your thinking's going. They can learn from it. And it just helps everybody to stay on the same page, which is really, really important. And you talked about, Tim, in that talk about how the anaesthetist arrived with her team and then suddenly actually they went really quiet and turned their backs on everything because they were getting their kit out and checking it. Well, potentially if they turned their backs to get their kit ready, but had carried on speaking out loud and sharing their mental model, going, yep, carry on, we're listening, we're just going to start getting the kit ready because this is a time-sensitive situation and we want to make sure and see what's here, then everybody would have had a much better idea of what direction you were going in.
I completely agree. And the thing I took away from this more than anything else was that shared mental model, because when the team came down, the fact they turned their backs on us and spoke very quietly, the only communication to us was, are you sure you've got the right size supraglottic airway in? So it was sort of arrive, criticize, isolate. And particularly the nurses found that really difficult, because they said that they felt that we lost team cohesion, we lost the mental model. And because we'd asked them to come down as the airway experts, it felt rudderless for a little while. And processing that takes about 30 seconds, which is why we said to the anaesthetic team, please turn around, face, share your model. And we, I guess, took back the leadership immediately. But that really taught me the importance of team integration. And also, just because you're calling someone as a procedure expert does not mean you're calling them as a leader. And I think for many things, thoracotomies, whatever, having a separate team leader whose job it is to integrate all into the room is the way to go. And while I was the team leader and I did the procedure, I did hand over team leadership during that time. And I think that's really important. You cannot have situational awareness while you're 100% focused on the surgical airway. It's just not possible. And to make that demand of yourself is to put yourself in a position where failure of process will result.
And this is something we've seen time and again in summer school when we've run really difficult scenarios, challenging interventions that need to be done. But often the most senior person is the team leader, and then they have to hand over in order to get it stuck in and to do that procedure. And that's the sort of reality of it. So I think that in handing over leadership and being really clear about it is just super important. Martin.
Yeah, I was just going to say just on that there's a lot of chat these days in pre-hospital about the flash teams, having to get that team integration with people you don't know from the other emergency services, whether it's critical care teams or police or fire or other paramedics. And I suppose I hadn't really appreciated it in hospital. There's maybe that naive sort of assumption that you take a patient into hospital and if patient deteriorates for whatever reason, people will know their role. But yeah, you're getting people you don't know from different specialities coming down. So it's not too dissimilar, which is interesting. Yeah. And some of those people are not used to that emergency kind of situation in a resource room. So it's interesting.
And likewise, people assume pre-hospital everybody's worked together before and they're all best buddies and come from the same ambulance base, whereas you've got ambulance bases scattered everywhere and you don't know each other. It's one of the joys of the master's program is that you're learning from the pre-hospital and the in-hospital teams and learning about each other's experiences and limitations, challenges, and therefore helping to build that sort of greater picture going forwards. Tim.
I mean, it's very much why our program includes doctors, paramedics, nurses equally in the same way. For a team to work well, you have to have mutual respect, and understanding other people's feet and eyes is a really good way to start mutual respect. And just to go back to this case, I was a locum. I'd been in that hospital a week. The guy that I did it with, I trained with, which is partly why I picked him, the other consultant, hadn't seen him for 30 years. He was a locum. He'd been there 2 days. The airway doctor was a British doc travelling through Australia where this took place, and she'd been in that hospital a couple of months. The nurses were all ED and had been there. The anaesthetic reg that came down first was a UK locum that had been there, I think, for a week from memory. So that team, as it was, had not met each other socially, worked together, or even really knew of each other's existence. So flash teams are very common in hospitals, I think. In fact, in my practice, more so than pre-hospital care. Pre-hospital care, particularly for HEMS jobs, and certainly where I am now in South Australia, because the teams are quite small and you're interacting with a reasonably small number of rescues and police, you can get to know the team in some months, and it tends to be the same faces come up. I know London's a bit bigger than Adelaide, Martin, so perhaps doesn't apply.
Just popping in the chat there, if anybody has questions about the master's program as well as about front of neck access or surgical airways, then do feel free to ask those too. We've got a couple of students on the call as well who may be able to help enlighten you or answer any queries. And we've got Chris, who's our wonderful administrator and lead everything that's technical and needs to be sorted out from the QM side. She's also got a new colleague working with her, which is called Amy, who's not here today. We've also got David, who some of you may have received emails from, who helps with the comms and new students and helping us to spread the word about these different events. So if anybody's got questions about that, do ask.
Not seeing a lot of hands go up, just checking the chat. Not seeing any questions there for now.
If you follow us on Twitter, or if you don't follow us on Twitter, but you're on Twitter, you will find us at Resus Masters, which is where we post these webinars and other events that are going on. So that's worth doing. And if you haven't had a chance to go and fill in the survey yet, we'd be really grateful just to let us know where you're joining from. And if you've got any questions, as Chris says there, you can send those through to our central email address, which is emergencymed@qmul.ac.uk. If not, enjoy your lunch. Enjoy your, well, I know some of you are on your way to work first thing in the morning, Romario, so I hope you have a good shift today. Maybe I know Tim is at the end of his day in Australia and heading towards bedtime, so I hope you have a good night. I'm in the middle of the day, so I'll hang here for a couple of minutes if anybody's got any questions.
I actually just got to work. So I'm still like, what, 20 minutes early? So I'll hang around for like 5 minutes more. I was going to say that in practice, I've never seen the front of net surgical airway before. Everyone tends to go to the ETT, so the endotracheal tubes, or like in the less sophisticated cases, they usually go to the oropharyngeal or the nasopharyngeal airways, which are quite easy to pass. But I've never seen a surgical airway being done there and then. I've seen afterwards, like after care when it's all staged in and the patient is stable, but I've never seen one being passed before. I think it's a cultural thing, really. Everyone just goes straight to passing.
Yeah, I mean, Ramiro, I mean,
Oh.
we would only do front of neck access if we were unable to pass a tracheal tube and unable to oxygenate the person. We're not talking about, none of this talk was about an elective tracheostomy. This is simply in the patients where you fail to intubate and fail to oxygenate. So you are unable to deliver oxygen that's compatible with life using either a supraglottic airway or a face mask, and you're unable to pass a tracheal tube. As you could see from the videos, it took a long time to position to find that larynx, and that larynx, well, it was obvious, but it was about 3 millimeters across. You could not have got a tracheal tube in it even if you'd found it.
Okay. Well, even in cases that the intubation was difficult, I've still never seen it before, and it usually leads to patient compromise and demise. So having that, visual experience observation, it's never been there for me. So hopefully well, I don't want it to happen, but I do have a chance to see it.
And Ramiro, there was a survey, I think it's something on about 1 in 20 emergency physicians in their entire life get involved in this. The reason I've been involved in more is quite simply I spend a lot of time pre-hospital, and I have a interest in the airway, and a lot of my involvement is where people simply have rung me through semi-professional friendship circles to discuss their experience. And I think even anaesthetists in theatre, if they're not doing A&T lists, most of them will finish their career with 0 surgical airways.
Yeah. Well, in terms of pre-hospital, the scope of practice for EMTs and nurses here are quite slim. So quite frankly, that wouldn't be done in the pre-hospital setting, and we don't really have doctors out on the field either. So what we tend to find is all of the, hard work is done in the hospital. Nurses are even allowed to insert IVs here in public practice. They are covered to do phlebotomy in public practice. So if you do want to get into these things in terms of advanced nursing practice or advanced practice, then you'll have to seek the public sector. We had spoke by email about why I chose the program, and like I said, in my response, that they're creating new posts and new specializations for EMTs, paramedics, and nurses that would allow us to do these things. So I'm just trying to get ahead of it. But naturally, as it is now, we're not allowed to do phlebotomy, IVs, none of these basic things that other nurses do in other countries, or in other Caribbean territories here in Barbados. So
that's very interesting to hear. I mean, where I am in Australia, I work in a team where the doctors and paramedics and nurses may put in art lines, central lines. Depends on the scope of practice, but I mean, certainly we've got some ICU nurses that are also paramedics. They tend to have trained for 20 years, and they've got a scope of practice from winching out of a helicopter to putting in a central line to getting arterial access to doing thoracostomies. And certainly in many countries, nurses have a reasonably large procedural scope of practice. So where I work, the nurses will reduce shoulders, will reduce wrists. I mean, Martin, within your scope of practice, you can do most of those things, I assume.
Interesting, not at the moment, Tim. I'm just my current role. I'm not an advanced practitioner in my role, but I work closely with a team. I line manage a team of advanced practitioners, so I'm able to pass on some of my experience. But this is what I'm really interested in this stuff because I work with them, and I'm sure none of my APs, I think one of them might be on the line or was on the line, would want to be involved in these, but they do happen from time to time. But not currently within my skill set, but has been in the past. But work closely with people in the Scottish Ambulance Service who can do this.
Right, that's interesting to hear. Equally, teaching them and giving the people that you're managing confidence to do those procedures has got to be key to their development.
Yeah, I mean, anything that makes what they have to do. I mean, I've got a great deal of respect for. I manage the advanced practitioners in critical care in SAS, and I don't have to tell anyone on this call the jobs they go to. They go into the biggest sick patients, and we don't always know what they're going to. Anything that I can help them do is to prepare them for that. I'm extremely keen to do. So.
And I'm sure you're doing it very well.
Yeah, who knows? We'll see. Yeah, maybe, hopefully.
Hopefully, indeed.
Super. Well, thank you very much, everybody. Thank you so much, Tim, for sharing your experiences. It's really helpful for all of us to hear it from people who've actually been through this and had these experiences themselves, and to see it all framed within the DAS guidelines and Vortex and everything else is super. So we really, really appreciate your time. Thank you all for joining us in your lunch break or in your commutes, and that's been fantastic. Please fill in the quick survey if you've got 2 minutes. We'd be really, really appreciative. Some of you have already, which is fantastic, and we'll keep you posted for any future lunch and learns that we host. Thank you.